Welcome to the University of Toronto Joint Center for Bioethics Seminar Series. I'm Angel Pichapunagos, and I'll be the moderator for today's session. Our speaker is Tegan Kilaki, and her seminar is entitled Advanced Care Planning in Advanced Chronic Disease, an Exploration of Relational Autonomy. Before I introduce today's speaker, I'd like to let you know that the seminar is being recorded. This lecture, along with other archived lectures, can be accessed through the Joint Center for Bioethics website. The format of our seminar today is a presentation by our speaker, followed by a facilitated discussion period. We would like to take a moment to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and most recently, the Mississaugas of the Credit River. Today, this meeting place is still home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. We also stand in solidarity with the ongoing protests against racism and systemic discrimination. Now, it is my pleasure to introduce today's speaker. Tegan Kilaki is a registered nurse and postdoctoral research fellow currently working at the Hospital for Sick Children. Tegan received her PhD from the Lawrence S. Bloomberg Faculty of Nursing at the University of Toronto with a specialization in bioethics from the Joint Center for Bioethics. During her doctoral work, Tegan was a trainee with the Ted Rogers Center for Heart Research and Toronto General Hospital Research Institute, where her research focused on improving patient and family experiences within heart failure care, with specific emphasis on enhancing patient autonomy and family involvement in decision-making and advanced care planning. Tegan holds a certificate in advanced training in qualitative health research methodology and is the Features on and Impact co-editor of the Nursing Ethics Journal. Now it's with great pleasure I turn it over to Tegan. Welcome.
Thank you so much, Angel, and thank you for the great introduction. So I'll jump right into it. I just wanted to highlight a couple objectives for the talk today. So I'm going to start off really briefly with some general considerations about how the Canadian population is dying. I'll talk a bit about current problems with traditional advanced care planning in relation to chronic disease management. And then I'm going to move into using heart failure as a case population to examine relational autonomy in advanced care planning. And then finally, I'll present some findings from my doctoral research that highlight how relational autonomy may be a more suitable framework for conceptualizing advanced care planning in advanced heart disease and other chronic diseases. So as many of you probably are already aware, the leading cause of death currently in Canada is cancer, but following closely after that is heart disease. And we don't often think about the impact of not only heart disease, but respiratory disease and other chronic diseases currently in kind of the role of death and dying in Canada. Taking that a bit of a step further, it's important to look at palliative care provision in Canada, and this is looking at Ontario specifically. And I just wanted to highlight that although heart disease is the second leading cause of death, cancer patients are 2.5 times more likely to receive palliative care than people dying from non-cancer causes. So there are some inequities that exist in our system in relation to access and provision of palliative care for patients living with terminal chronic diseases. I'm sure many of you have seen similar types of graphs before, and I won't spend much time on this, but I did just want to highlight the difference between cancer and kind of the chronic organ failure groups in terms of illness and end-of-life trajectories. So although this is changing with kind of improvements in cancer therapies and innovations, often we'll see cancer patients be quite stable for a period of time and then move into the end of life period with a rapid decline. And so it's quite clear when that phase is occurring and when important decisions need to be made. In comparison, for diseases of organ failure like heart failure, chronic kidney disease, COPD, et cetera, we see more of an up and down trajectory. So patients have periods of acute kind of disease exacerbation and then recovery to not quite baseline, but close enough to baseline. And this can occur for decades. So it's a little bit harder to tell when patients are entering that end of life phase and when some of these important conversations and decisions need to be made. So just to move into a little bit of a discussion of advanced care planning. Historically, advanced care planning was seen as a way for individuals to exert their autonomy by controlling life-sustaining treatment decisions beyond the time at which capacity may be lost. So this was primarily achieved through documentation of an advanced care directive, or a living will, as some people call it or know it. And in this model, autonomy is exerted at one discrete time point by one individual when they sign that document. It's very similar to the way we've conceptualized the process of informed consent. More recently, however, our understanding of advanced care planning has shifted to seeing it as more of a process that enables people to define goals and treatment preferences for future medical care and discuss these with their family and their healthcare providers, with the overall goal of ensuring that people receive care that's consistent with their values, goals, and preferences. However, this newer model still assumes that personal values, wishes, beliefs, and goals are being currently incorporated into decision-making and informed consent throughout the illness trajectory. So as I mentioned, kind of currently, the definition or process of advanced care planning has shifted to become a lot more broad and can include adults at any age or stage of health, does not need to be limited to people at the end of life, and really focuses on sharing personal values and goals, as well as including and preparing another trusted person, such as a substitute decision maker, to be able to make decisions if the patient themselves is not able to. As mentioned, this is all based on the principle of respect for individual autonomy. And although this is broadly conceptualized as a kind of process that occurs over time, in practice and research, we see that the focus really remains on documentation, whether that's documentation of advanced care plans in Ontario or different types of documents in different jurisdictions. So what's happening currently in practice? We know from the research that advanced care planning is considered important to patients, families, and healthcare providers, and that all of our clinical guidelines recommend discussing advanced care planning early and often in the chronic disease trajectory, yet participation remains low. So you can see from these statistics that the majority of heart failure patients don't know what advanced care planning is. There's a minority of end-stage renal disease patients who complete advanced directives, and a small amount of COPD patients who have discussed ACP with clinicians. And what we hear a lot is that chronically ill patients often do not view themselves as terminally ill the way that cancer patients or other populations of terminally ill patients might, which is a big barrier to their involvement in advanced care planning. So I just wanted to briefly touch on some of the problems with advanced care planning that are kind of currently conceptualized in the literature. And this is a fantastic paper by Stephanie Johnson and her colleagues in Australia. And she really highlights how we're really asking advanced care planning to do a lot of heavy lifting here. We're looking for it to not only be a solution to an ethical problem, which is ensuring patient autonomy, but we're also looking for advanced care planning to be a solution to an applied problem, which is improving end-of-life care, making sure that care is congruent with wishes and values, that providers perhaps feel less moral distress when they're providing end-of-life care. And we're really looking for it to do quite a lot. They also note that advanced care planning interventions are based on the assumption that respecting and extending autonomy is really central to achieving a good death. However, this correlation isn't necessarily supported in the literature. And they do highlight how chronically ill patients identify that achieving a sense of control is important to them, but this type of control or understanding of control isn't actually framed as control over individual healthcare decisions. Instead, patients are looking to be respected, listened to, and have their psychosocial concerns consistently addressed. And just a little bit on the kind of patient perspective of advanced care planning and what patients are thinking and feeling. From what we know, they see advanced care planning as being based in personal relationships, and the goal is relieving the burden placed on others. They rarely discuss advanced care planning in terms of control or influence over treatment choices, and patients generally accept that their wishes might vary during the course of an illness, and that their expressed preferences for care might not always be followed. Generally, patients are happy to delegate treatment decisions to trusted professionals, and overall, the literature indicates that maybe patients don't actually value traditional individual autonomy at the end of life. So all of this is kind of setting up for where I was when I was starting out my doctoral research and wanting to take that a step further and understand, okay, if this model of autonomy isn't resonating with patients, what can we do differently, and what other models might we explore? So I'm going to move into speaking about my doctoral research project specifically, which was looking at advanced care planning in end-stage heart failure. So as I kind of mentioned, and you all probably know, cardiovascular disease is the leading cause of hospitalization and second leading cause of death in Canada. And heart failure specifically is a chronic, progressive, and terminal illness. And patients have quite a poor median survival rate after being diagnosed with heart failure. As we're able to treat cardiovascular disease with increasing therapeutic innovation, more people are living on to develop heart failure, leading to it becoming an epidemic in Canada. So similar to that first graph I showed you earlier, heart failure patients are extremely complex and have very unpredictable disease trajectories. And this is not only because of the illness itself, but because of the variety of therapies and technologies that are available to patients throughout the course of their illness, such as implantable cardiac devices, non-invasive valves, ventricular assist devices, and transplantation. So as I mentioned, heart failure is a good example of a disease that is characterized by periods of stability and periods of disease exacerbation with unplanned hospitalizations, procedures, and intensive care use, along with challenges prognosticating and anticipating the end of life phase. So this means that patients often end up dying in hospital after receiving intensive medical intervention, despite evidence that they may prefer to die at home or in the community with more supportive measures in place. And because of this, advanced care planning is recommended to take place proactively. So our literature review in this area was published in the Canadian Journal of Cardiovascular Nursing. And we reported that, again, the majority of heart failure patients do not participate in advanced care planning, despite over 30 years of research, intervention, and awareness campaigns. The literature conceptualizes patients, as I mentioned, as autonomous, rational individuals who are readily and easily able to access a set of stable desires and preferences, and then document these preferences and communicate them in a meaningful way for the healthcare team. However, at the same time, we see that patient preferences are actually extremely challenging to predict, and they change frequently throughout the disease trajectory and into the end of life phase. And overall, the literature is largely positivistic. So ACP is assumed to be an inherent good that people should participate in, and therefore interventions focus on individual level behavior change. And the research really lacked an analysis of broader institutional and social forces that may influence this process. So to talk a little bit about the theoretical underpinnings of this study, although respect for autonomy, individual autonomy is assumed to be the philosophical basis for advanced care planning, it really fails to account for the prevalence and importance of relationships, not only at the end of life, but throughout the course of chronic disease management, which can be decades long for heart failure patients. So one of the goals of this work was really to provide a reconsideration of the practice of advanced care planning based in feminist ethics, which puts forth a relational approach to autonomy as an alternative to the dominant individualized framework. So relational autonomy, as I mentioned, is really developed through feminist ethics and emphasizes the socially embedded nature of people. Relational autonomy sees the ability to be self-directed as affected by social and political forces, and puts forth that relationships really shape the way individuals construct their self-identities throughout their life. Another key piece of relational autonomy is this idea of social location, and that social location determines the types of opportunities that are available to people to actually support the development of their autonomy skills. So in previous work, we've actually argued about the merits of relational autonomy in advanced care planning for chronically ill patients. And through that work, we really highlighted that a relational model of autonomy is well suited to exploring ACP in chronic illness for four main reasons. So the first is, as we mentioned, it recognizes the importance of relationships during this really crucial time. And in a practice such as advanced care planning that really relies on relationships such as those with substitute decision makers. Relational autonomy also reflects the fluctuating nature of autonomy in chronic illness. So again, diseases such as heart failure can have pretty significant consequences for cognitive functioning. And it means that patients are often in a fluctuating state of cognitive capacity and therefore potentially of autonomy as well. Relational autonomy recognizes vulnerability and the vulnerability of patients within the healthcare system specifically. And finally, is consonant with some of the empirical work I already mentioned that looks at advanced care planning from the perspective of patients who really see this as the process that takes place in the context of relationships. So our study was guided by three research questions. We were interested in knowing more about how people understand advanced care planning, how they express their autonomy when participating in advanced care planning, and how social location mediates participation in advanced care planning. So as mentioned, the study was guided by feminist ethical theory, and there were three key concepts that really framed the work. The first is relational autonomy, the recognition that autonomy is developed through relationships, and self-direction is defined and pursued in a social context, and this context really influences the opportunities people have to develop or express their autonomy skills. Social location consists of ascribed social identities, social roles, and relationships. So these are things like gender, race, sexual orientation, ethnicity, as well as things like occupation, family positioning, religious affiliation, etc. And our final key concept was medicalization, which involves people viewing a problem, condition, or life circumstance in medical terms, using medical concepts and discourses to describe normal life phenomena such as birth or death, and accepting the use of medical interventions as the most legitimate way to treat these conditions. So the methodology for this study was a critical, qualitative, multiple case study approach. Case study is characterized as an empirical inquiry that investigates a phenomenon in depth and within real life settings. So in this case, the phenomenon of interest was the experience of advanced care planning. Cases were constructed starting at the individual level by recruiting the person with advanced heart failure. And then we moved outwards to capture the interpersonal level, which involved family members and healthcare providers. Finally, we also examined the institutional and social level, which involved analyzing policies, legal documents, and educational materials. The benefit of this approach is that it facilitates the examination of multiple relationships among different types of participants and different types of data. So as you can see, there were a variety of data collection techniques used, primarily semi-structured interviews with participants, as well as observation and field notes and a document analysis. So overall, there were 7 cases in this study, which were comprised of 24 participants, 19 interviews, 11 documents, and over 500 pages of data. I wanted to kind of use this case study database to also highlight the specific social context relevant to each of the cases. And I wish I had time to share every participant's story in depth, as they all had such unique experiences and illness trajectories, which I think really highlights the complexity and heterogeneity of the heart failure population. But as you can see, there was a large age range of participants, a wide variety of healthcare provider types. So not only cardiologists, but nurses, palliative care providers, bioethicists, social workers, and a variety of different documents included. And this is one of the biggest strengths of this work, as using case study methodology allowed us to capture a really diverse data set and provide a holistic understanding of the experience of ACP. So there were 3 key findings that resulted from this work. The first is that ACP was a complex social process, often positioned outside of standard treatment decision-making within the biomedical model. The second was that the agency of patients was constrained in advanced heart failure due to the limited understanding of complex information, limited treatment options, and the protocolized nature of decision-making. And finally, the findings indicate that autonomy in ACP was shaped heavily by interpersonal relationships and responsibilities, as well as power dynamics and broader social forces. So I'll explore each of these findings in depth. But overall, patients' experience of autonomy was incongruent with the dominant individualistic approach that's currently used to structure advanced care planning interventions, and instead was a relational experience. So many participants in the study weren't actually familiar with the specific terminology of advanced care planning, although there were 2 types of future care decisions that people generally referenced. The first was heart failure treatment decisions, such as medications, devices, therapies, etc., which were driven by the healthcare team and guided by overarching protocols, guidelines, and candidacy criteria, which we'll talk more about. These decisions were framed by the biomedical model of decision-making and were seen as outside of the control of patients. Then there were personal decisions, which revolved around after-death legalities related to finances, wills, burial arrangements, etc. And these were guided by the legal model of decision-making and were understood as things that participants did have control over. ACP was primarily understood as this type of personal process: finances, wills, and legal agreements. So as an example, when asked about her experience with advanced care planning, Judy, who was a nurse practitioner working with heart failure patients, immediately relayed her experience supporting her mother and aunt throughout the financial and funeral planning process. Judy wasn't the only healthcare professional who related ACP to personal experiences. Many healthcare providers used examples to describe end-of-life decision-making in their own families, as opposed to providing clear examples of their professional role in ACP, or even their experiences integrating patient goals and values into their treatment decision-making. Taken together, this understanding reflects how ACP can be seen as external to treatment decision-making. Participants connected ACP to aspects of life outside of the healthcare system and even outside of the medical context, such as prepaying for funeral expenses, which may have influenced their ability to approach and participate in ACP within the context of clinical relationships. When the legal and biomedical models of decision-making did overlap, the process of ACP was reduced to obtaining a code status or determining resuscitation preferences. For example, when discussing ACP with Andrea, who was a nurse and director of care at an assisted living facility, she noted that during her initial assessments, she asked what the residents' wishes are, but then in the next phrase immediately dictates this means they either sign for CPR or no CPR, and that is the extent of their decision-making. Many patients also initiated discussions of DNR with me during the interviews, and they were clearly familiar with the concept. The healthcare decisions that patients viewed as under their control related specifically to refusing resuscitation, but seemed to exclude decisions about the treatment plan leading up to the resuscitation point or any involvement in conversations regarding consent to treatment. So although ACP is outlined in theory and in research as an attempt to overlap these 2 spheres of decision-making and bring personal preferences, values, and goals into treatment decision-making, in clinical practice, ACP was often reduced to decisions regarding resuscitation. Documentation of a DNR underpinned by the overarching power of the legal model was seen as the only way for participants to exert their autonomy in the healthcare system, both by healthcare providers and by patient participants. The legalities of consent, combined with the dominant view that biomedical treatment should be pursued until the time of death, really created a very limited role for patients looking to participate in ACP, and the only method available to them to help enact their autonomy was DNR documentation. So the second research question sought to understand how participants express and experience their autonomy through the process of ACP. To do this, it was first necessary to outline how people's experiences may or may not align with the way individual autonomy is traditionally enacted in the healthcare system through the practice of informed consent. This ideal of autonomy and informed consent is characterized by three requirements, which I'm sure many of you are already familiar with. The patient must have sufficient information to make a decision, a range of significant options to choose from, and must make their decision voluntarily without coercion. When I mapped the experience of autonomy of the participants in our study, there was significant incongruence between their experience and the traditional model, as participants highlighted the impossibility of being informed, the way that the protocolized and guideline-driven heart failure care system dictated their options, and the coercive power of death, which favors decisions to extend survival by accepting treatment. This highlighted a key finding in this study, which is that agency is constrained in advanced heart failure, and ACP does not align with the individualistic view of autonomy that it's traditionally been associated with. To expand on the impossibility of being informed, it's helpful to contrast Daniel's experience as a cardiologist with Han's experience as a patient, trying to determine whether to move forward with a heart transplantation or not. Daniel describes the challenges he faces, explaining prognostic curves and mortality rates to patients, and expresses that he even struggles to teach medical residents about heart failure, and that experts are unable to accurately estimate prognosis for patients. At the same time, Han really struggles with this uncertainty, as he logically knows he is sick because he takes medication, but he can run around and feels well. So he says, at least I'm not dying yet. Or maybe I am dying, I actually don't know. This really demonstrates the impossibility of being informed in the way that patients have to make future care decisions in the dark about their current status. Secondly, heart failure treatment decisions were shaped by strict candidacy criteria. Decisions were not based on preferences or values of the patient, nor were even understood to be under the control of individual healthcare providers, but were instead framed as decisions that were dictated by the larger power of a neutral candidacy criteria, which deemed patients acceptable candidates or not candidates to receive various therapies. Because of the power of these guidelines, there were limited opportunities for participants to develop autonomy competencies related to healthcare decisions, and candidacy criteria and guidelines were viewed as the only legitimate way to address the illness. Because of this, patients often viewed themselves as having quite a passive role in healthcare decision-making and having no choices. Their options were limited to accepting treatments proposed by their clinicians or refusing. However, the risks of refusing treatment often meant certain death. In addition to Nathan and Peter, other participants noted that even when they did not wish to receive a certain therapy, such as Han, who didn't wish to receive an ICD, they were told they had to move forward with the treatment or else they could die at any time. This demonstrates how even when patients might have specific preferences in relation to treatments, they're often disregarded or rejected in favor of prolonging life at all cost. Agency is therefore constrained when patients construct consent to treatment as their only choice, as is the case in advanced heart failure. Choosing between various medical treatments was not something that patients and families saw as within their domain of control. And patients described how they were not asked about their wishes or treatment preferences. And in fact, they often didn't have specific desires or preferences for care, but they had instead preferences for how they would like to live the remainder of their lives. And often this involved merely trying to stay alive for their loved ones. This last set of results demonstrates how autonomy is deeply connected to family roles and responsibilities, relationships with healthcare providers, social location and social identities, and is influenced by social discourses such as ageism, individualism, and self-management that stem from neoliberal ideology. So these excerpts from Han, Nathan, and Sarah's interviews demonstrate how decisions were constructed in family life, and the way people made decisions was based on what was best for their family and not just for themselves. Families were expected to want to have each other around, and patients were expected to want to continue living, to spend more time with their family members. The experience of participants was very different than the viewpoint portrayed by traditional individualized theory of autonomy that focus on rational decisions motivated by self-interest. As an example of the role of social location and social forces, age and ageism were both highly influential in ACP. Despite being defined as something that should be relevant for all adults, there was an underlying discourse of ageism that targeted ACP specifically at those who are older. Healthcare providers and governments want elderly people to make the right choices by completing ACP documents to reduce intensive interventions for these populations at the end of life. In this study, there was a sense that when patients were younger, ACP was not relevant because everything possible should be offered, or they were not yet at the point to discuss ACP. If young patients did not want extensive treatments, such as ICDs or resuscitation, this was seen as the wrong decision by healthcare providers and was not easily accepted. Comparatively, when patients were older and had fewer responsibilities, there was a different assessment of the moral and social value of their lives and the value of keeping them alive with intensive intervention. So autonomy was shaped by relationships with family members and healthcare providers who were powerful and deeply influential in decision-making. Secondly, factors such as age, gender, culture, as well as broader social and political forces shape the experience of ACP. And overall, conceptualizing autonomy as a relational experience that captures these factors may allow people in a variety of social locations to participate in the process, as opposed to only those who identify with the traditional individualized approach to autonomy and decision-making. So the overall results suggest that there are diverse ways of understanding advanced care planning in advanced heart failure, yet there's little connection between the traditional individual model of autonomy and the realities of decision-making experienced by participants. Signing a DNR was seen as the only method for patients to exert their autonomy, yet DNRs are rarely recognized as an attempt for patients to be involved in broader treatment decision-making. Going forward, it might be worthwhile for healthcare providers to recognize that if patients are pursuing a DNR, there's also a need for further conversation regarding broader treatment plans and goals. A second key finding of the study was that due to the severity of their illness and the impossibility of being informed, patients were required to trust healthcare providers and institutions to guide decision-making. Additionally, opportunities to develop self-trust within routine healthcare processes were not available to most patients. Current models of decision-making do not set patients up to be well prepared and able to participate in ACP. However, by using a relational approach and focusing on self-trust as a modifiable outcome, there's potential to better engage with patients and provide them with opportunities to build their autonomy skills over the course of their illness. Ultimately, autonomy was governed by wider discourses that prioritized the pursuit of biomedical treatment and the primacy of evidence-based protocols and guidelines over the development of autonomy. So in conclusion, this study challenged the current literature that often portrays ACP as a simple process grounded in individual autonomy, and by using a new approach to study this issue, expanded our understanding of the complex intersecting web of relationships and forces that shape people's ability to participate in ACP. Using a relational understanding of autonomy also allows us to acknowledge the role of nurses in engaging with patients and their families about life goals that may not be directly related to treatment choices, such as personal and family-oriented goals. This also begins to highlight the way that approaching ACP through the lens of important relationships, as opposed to specific individual preferences, might be more fruitful. Educating clinicians about broader power dynamics and social forces that shape decision-making may allow providers to understand the nuances associated with practices such as ACP beyond merely framing this as a simple problem of individuals not participating in the practice. Excitingly, the Pan-Canadian framework on ACP has recently shifted from using an individualized to a relational understanding of autonomy, but more research is still needed to determine how this can be fully implemented in the Canadian healthcare setting. And finally, further empirical work is needed to explore how this relational approach can improve the experience of advanced care planning for patients with a diverse range of chronic illnesses, and beyond ACP, how this approach could potentially improve healthcare decision-making in a broader context throughout the illness trajectory. So in conclusion, I just love this quote, back to my favorite study by Stephanie Johnson and her team. But they kind of end by saying, improving end-of-life care is not an easy task, particularly as care becomes increasingly fractured, technology-driven, and complex. It is unlikely that any single mechanism, particularly one that emphasizes decision-making, such as ACP, will achieve sufficient quality care. This suggests that we should look beyond ACP to the broader political and moral foundations of care. And finally, I would just like to acknowledge my amazing doctoral thesis supervisor, Dr. Elizabeth Peter, and my committee members, Drs. Jane McIver and Sean Mohammed, and all of the generous funding I received to support this research, and would be happy to take any questions or comments. Thank you.
Thanks so much, Tegan. That was really great. So we're now at the discussion portion of today's seminar session. So I just want to remind our viewers that they can type their questions into the YouTube chat. If they're not logged into YouTube or would like to send the questions anonymously, they can do so by sending an email to lori.bulchak@utoronto.ca. And I think her email is listed in the YouTube chat there as well. Okay. So we're going to go to our first question here. So Judith Wall comments that in her research as a lawyer, she sees more people not wanting to write down advanced care planning wishes. Rather, they choose to communicate these orally to their future SDM to guide them when the SDM might have to make a decision in the future. So I wonder if you have any thoughts, Tegan, on patients who don't want to write down their wishes, or also if there are patients that don't have any to share. And for this group, would there be other information or processes for supporting their relational autonomy?
For sure, yeah. So not wanting to write them down and then not wanting to share. I think those are kind of maybe two separate issues, but it's a great point. And to me, it makes a lot of sense because often, at least for this group of patients, may have been living with their chronic illness for many years or many decades. And they're not often the ones who are leading or driving decision making. And so it's actually a huge, I don't want to say burden, but a huge responsibility we're asking them to take and write down some directions they feel that are then set in stone in a way that a legal contract kind of seems to be when something is written and signed. So having that verbal option of communicating to a family member or an SDM, I think leaves a lot more room for flexibility and an interpretation, and for them to say, these are kinds of the things that I feel are important to me, but what we see is that patients really want their trusted loved ones to make the decisions with the information they have at the time. And they recognize that they probably don't have all that information now because things change and fluctuate so rapidly in chronic illness. So I think the idea of not wanting to write things down and feeling like they're set in stone makes a lot of sense. And I think encouraging the conversation is a great place to start. So if that's all they're willing to do, I actually see that as a lot more meaningful a lot of the time than what we get written down in an ACP or an advanced care directive, which often isn't even applicable anymore to the patient's situation, depending on the current state of their health. So having kind of ongoing conversations with loved ones or SDMs is actually, I think, really beneficial, and encouraging those conversations would be a great place to start. If people don't want to share, that's another thing is that we saw that a lot of patients didn't feel that sense of really strong personal individual autonomy or control over these decisions. They really felt like these decisions were out of their hands and they were trusting their providers to make those decisions. And if that's kind of how people feel, we can't really force them into putting together a list of preferences or wishes. when they might prefer to delegate those decisions to others in their circle. So I think the best thing we can do to support the relational autonomy of people is to offer them opportunities to be involved gradually over the course of their illness, so they develop some of these skills, and we don't just thrust them a piece of paper or a very intense and high stakes decision right at the end of life when they're, quite frankly, at one of their most vulnerable states. So that would be kind of my response to that, and I hope that's helpful.
That's great. That is helpful. It aligns with some of the things that I've seen in my own practice, where just letting patients know that they can tell people and that they don't have to have wishes for the future, but if they do, those things matter.
Mm-hmm.
Because at least here in Ontario, so depending on where they're coming from, they might not, right? So it's I found that it's been I think beneficial to patients to just know that their wishes do matter and that there's an opportunity to share them if they want.
Absolutely, yeah.
So related to that, I have a couple questions, and I'm also picking up on some of the comments from our audience as well. And there's a couple different parts. So the first part is sort of in these discussions, particularly when people don't have any wishes to share. I think most people still have values and beliefs. And in Ontario, at least, values and beliefs matter. They're relevant in terms of determining what's in a patient's best interest if they become incapable, and the SDM has to decide. So I wonder if you can say a bit about what you might have learned about the sharing of values and beliefs in advanced care planning conversations, and then the perceived importance of that or opportunities for patients with respect to their autonomy. Now, the second part of that question, and this is just picking up on some of the comments, in particular a comment from Judith Wall related to the different jurisdictions or legal contexts. So maybe you could say a bit more about sort of your interviews. I might have missed it if they're all in Ontario, but also in your research, if you're looking at other places, other provinces or countries and advanced care planning, and if you noticed any differences that related to the particular healthcare consent laws in those areas and how they might impact the advanced care planning process or the characterization of it and how it relates to autonomy.
For sure. Yeah, I'll start with that piece first, just because everything was conducted in Ontario. So it was very much focused just in kind of the way our legal system is set up here and the way that we understand advanced care planning. I think definitely there's the piece that, of course, the different legal systems influence where you are. And I think the other piece that most people are also already familiar with, which is that we've imported all this terminology from other jurisdictions. And so often, as I mentioned, people really weren't familiar with the idea of advanced care planning. Sometimes things like a living will or advanced directive would ring that bell for them. As we know, that's terminology from other locations, and that's not really the framework that we have here. But that goes to show how influential media and other kinds of things are in this area and in this space, and thinking about how people think about that and conceptualize that. So all of this was really focused in Ontario, and the goal really wasn't to kind of fact check their knowledge of advanced care planning or try to educate or make them understand. It was more to get a sense of how do you approach this idea of incorporating values and beliefs into treatment decision making. And that was kind of the underlying crux of the research. And so kind of moving into that piece, I think it was really tough because there seemed to be generally just a real lack of opportunities for people to bring those two spaces together. So people might have general values and beliefs in their life. However, they weren't often asked about those. And so even less so were those values and beliefs brought to bear on the treatment decision-making that was happening in the context of their illness. So I think if people feel like they don't have any to share, it might be the way we're asking the question or the context where it's occurring. And we probably need to think about other ways to ask people about what's important to them. But I I mean, sitting down with these participants for an extended amount of time, you get a sense of what's going on in their life. And I think that's one of the key things that's just missing in the majority of our conversations, is just the ability to sit down with people for an hour and talk to them. No healthcare provider I know has that amount of time to spend. And so often patients don't have, as I mentioned at the beginning, a really formalized, articulate list of preferences or beliefs or values that then can just be imported into an advanced care plan. It comes out through conversation and through finding out who's important to them in their life and what's going on. One of my participants was getting a puppy, and it's things that require almost a translator or an interpreter to sit with them and help guide through, okay, these are the things that are important. And that's kind of what I mean in terms of when we have a really high expectation of patients being able to identify all these things that we call preferences, values, and beliefs, and then document and communicate them in a meaningful way to the healthcare team. It's actually quite a huge undertaking. So.
I'm curious, in your discussions, did any of your participants understand advanced care planning as consent, as a consent discussion, or no? Okay.
No one even was familiar really with the concept of consent, other than signing a form on their way to an emergency surgery or something like that. So there was really limited in the sense of feeling any type of ownership over a decision, even consenting to a decision being made. Often they didn't see that a decision had been made necessarily, or if there was a decision made, it wasn't them who had made it. And maybe they were agreeing to a plan, but the term consent almost never came up with the patient and family participants.
It's helpful, thank you. So we have a question from Tim. They say that I believe the ethics in practice considers the ethical, legal, and social landscape instead of the siloed single-lensed approach. And they wonder if there were any cases that arose whereby the treatment decisions were made by the Office of the Public Guardian and Trustee, for example, and how the relational or lack thereof approach worked. So I think they're asking if decisions went to the PGT, right, how that worked to support relational autonomy of the patient.
Yeah, so unfortunately not in this case, because everyone had to be able to consent to participate in the research study itself and the interviews. So, and as I mentioned, our recruitment strategy was to really start at the patient and then move outwards around in terms of the relationships that surrounded them. So it wouldn't have been possible for me to identify someone who had their decision making go to a public guardian and then go from there, although I see kind of the complexity there and how that adds a completely different layer to it. Everyone that I spoke to was able to kind of participate and consent and conduct an interview or multiple interviews. So unfortunately, I don't have an example of that I can speak to.
In your advanced care planning discussions with participants, had they all identified who their SDM would be? And in that group, did anybody have sort of the PGT as a decision maker as last resort because they didn't have any family or hadn't made any
I see what you're saying.
POA document? Yeah.
There was one person, my one lady, Diane, she was an elderly woman with not a lot of immediate close family, but she did have one niece who she had kind of put in charge of all the kind of legalities and documents. So there wasn't anyone who I guess was aware or had chosen or would know that it would go to the PGT. I think it would only be the circumstance, right, if people had refused to take on that that responsibility at the time, that maybe because of the hierarchy it would end up there. But everyone in the study had someone close to them that was either the default or who they'd already identified as would be that person.
Did you find that the advanced care plannings prompted any participants to appoint somebody different to be their SDM? In having the conversations, was there a point where they said, "Oh boy, like this would be my SDM," and I don't think they would follow my wishes here, so I'd rather have this other person?
Not so much. Like there was some joking kind of in the families in terms of this is why it is who it is. Like we've thought about this, and my wife is a nurse and she's very health literate and knows how to advocate, and so it's going to be her no matter what, and that type of thing. I don't think there was anyone coming to the realization of maybe this won't work, but I also don't know if people always fully understand what's being asked of an SDM, because often if their involvement in their own decision making for their illness is quite limited, they might not realize that there's much of a role or an expectation for an SDM anyway. So writing anyone's name down might seem fine to them, and that this person can handle it without maybe necessarily understanding the full scope of that responsibility.
Thanks. So we have a few different questions or comments related to Indigenous peoples in this context. Maybe I'll read them out and just give you an opportunity to respond to them.
Yeah.
So Eunice Gorman says that Indigenous people and many other cultures practice autonomy and relation. They are not as individually focused as North American societies and are instead connected to the family or group. And they add that they're speaking of research done with Maori people and connected to the development of cultural safety. Mm-hmm. And then on a related point, Tim adds that it is challenging to group all Indigenous people into one mode of thinking. Indigenous people, through definition, are the Inuit, First Nations, Métis, and urban Aboriginal people. And so this is in the Canadian context. Within First Nations, there are hundreds of reservations. And they share that they're from 6 nations where they have 6 tribes, therefore 6 languages and longhouses. And then they just added halfway through genocide, like this isn't exactly the case now. But I wonder if, in thinking of, so first, if you could share if any participants in your study identified as Indigenous, and if so, if you learned anything in particular about those perspectives that you can share. And if not, if you have any general comments you'd like to share.
For sure. Yeah, no, thank you for that. And it's a fantastic point to bring up. And I completely agree. I think so first of all, none of my participants were Indigenous. We did try to get a diverse range of participants, but unfortunately, no one who identified as Indigenous. But there is a lot of research coming out of Asia on advanced care planning and just generally the concept of relational autonomy and decision making there, and that it just aligns much more coherently with the way they've been making decisions forever, as opposed to this kind of traditional individual model that we tend to push on people. And I actually think that relational autonomy aligns much more even with the way we make decisions here in North America within our families than we necessarily give it credit for, and that we're not actually these individual islands or atoms, or however you want to think about it, that are only making rational decisions based on self-interest. That I don't think is the way anyone really makes decisions. And so I think one of my a researcher who I love, Rebecca Sadore, who does a ton of research in advanced care planning, always talks about this idea of what are you having for dinner next Tuesday, and thinking about how you make that decision. And it's not just like, I want pizza, so I'm going to get pizza. There's a whole spectrum of who am I eating with? Are there groceries in the fridge? Can I easily access food? Where am I accessing that food from? Does someone I am eating with have allergies? Like all the decisions we make are much more kind of, I think, closer to a relational model than an individual model. And so the fact that it aligns closely with other communities such as Indigenous or Asian communities, I think makes a lot of sense. And I hope that would lend it to become a little bit more popular going forward, and hopefully seeing the value in this for everyone, and not needing to group based on a specific cultural identity, but just the fact that as humans, this makes a lot of sense in the way we live socially connected to each other.
Thank you. So Bob Park adds that when we work with people living with intellectual disabilities, using supported decision making is helpful. Mm-hmm. And it's also helpful in a relationship with a person who knows them well. And this can include a healthcare professional.
Yeah.
And also these conversations can occur along the life course, not just in end-of-life care. Would you like to say anything to Bob's comment, add anything there?
Hi, Bob. Yeah, I totally agree with all of that. And I didn't get a chance to mention it, but yes, in my thesis, I did have a section on supported decision-making, specifically looking at the disability research community and how they've been able to address some of those challenges. And I think it really aligns and makes a lot of sense, especially when we think about from the perspective of vulnerability and what we expect of patients. Just because they have heart failure, they might be vulnerable in other ways, and learning from some of these models that you've mentioned, it can be really useful.
In your study, do you know of participants that may be identified as disabled, and or do you know if advanced care planning is if there's more of an uptake in that community or less, or how it compares?
I don't know specifically. I don't think anyone, I didn't ask that question about identifying as disabled. A number of them did have physical limitations because of their illness. And I, again, this wasn't, this was really based on their perspective. So I wasn't going into their charts and reading their entire medical history. I really wanted to get their understanding of their illness and their experience from them. And that really didn't come up very frequently. It definitely seemed like the group of again, and this is a super small sample size, so we can't generalize by any means, but the group of patients who were more elderly in their 80s and 90s had definitely thought about this a lot, were very familiar with this idea of DNR, even most of the patients were. But yeah, so I think age is one thing for sure that contributes to it, along with that recognition of really the decline that's happening. So some of them were starting to really notice changes in their functional status, which influence their ability to think, okay, maybe I need to think about this a little bit more. So those are some factors that I think are influential, but there's a lot of other pieces as well.
Thanks. And we have time for one more question. So the last question comes from Serena Eisenberg. They ask, can you talk a bit about your sampling frame and how you recruited participants?
Oh, hi, Serena. Yeah, absolutely. So we recruited from 2 different study sites. So this was important for us to be able to sample from 2 different heart failure clinics. They were both tertiary care center heart failure clinics, but one specialized in very kind of advanced therapies and had a younger kind of cohort average age of patients. The other was more of a community style clinic and saw patients who were generally older, but a little bit more complex in terms of comorbid conditions. So that was important for us to be able to sample from more than one institution and get a variety of perspectives, as well as from the healthcare providers and from the organizational context in terms of how advanced care planning is being presented and how people are being educated on it from an organizational standpoint as well. And then, yeah, as I mentioned, we kind of started the recruitment really based at the patient level. So they were referred to us through their healthcare provider, either cardiologist or nurse practitioner. And then if they consented, we would move on to also include close family members and healthcare providers that they identified as important to them. So that was kind of the way we tackled the sampling.
Great, thank you so much, Tegan. So unfortunately, it's time to draw today's seminar to a close. I do have a couple of announcements to make before we thank Tegan. Our next seminar will be on Wednesday, March 17th. Jennifer Chandler and Christy Simpson will be discussing ethical and legal issues with respect to a brain-based definition of death from an organ donation perspective. To sign up to receive our weekly seminar reminders, you can please send an email to jcb.info@utoronto.ca. And just a reminder for the CSB students who are enrolled in the CSB Student Seminar course, please remember to keep track of your attendance. And last but not least, Tegan, on behalf of all of us, thank you so much for your presentation today. I really enjoyed it.
Thank you so much for having me. It was a pleasure.